As I mentioned earlier, there are over 2,000 known mutations that are divided into 6 classes. In general, each CFTR mutation results in either a less functional or a completely non-functional protein. Each class is slightly different, however, so I will spend a moment on this slide going through each of the 6 classes individually and mentioning some types of mutations that are common for each of those classes. Class 1 is a situation where no CFTR protein is synthesized at all. Some mutation examples of class 1 are G542X and W1282X. In this case, no CFTR protein is synthesized at all, and therefore there is no protein available to be trafficked to the surface of the cell, to the apical membrane, and be functional. This is the most difficult type of mutation to treat because there is no protein even synthesized to possibly rescue. The class 2 defect is a trafficking defect, and this actually tends to be the most common mutation type because this is where the F508 deletion mutant falls, among others. In the class 2 defect, CFTR protein is synthesized, but it is not properly trafficked to the apical membrane. It gets stuck in the endoplasmic reticulum and the Golgi and never makes it to the membrane to be functional. Class 3 is a loss of function mutation. The primary example here that I've already mentioned is the G551D mutation. In individuals with a class 3 defect, CFTR is synthesized, it is trafficked to the apical membrane, but once at the apical membrane, it is non-functional and does not process or transmit chloride across the membrane. A class 4 defect is a decrease in function, but some function is retained. Examples of mutations here include R117H. And individuals with class 4 defects do have some CFTR function and therefore may have a less severe form of cystic fibrosis. In this case, CFTR is synthesized, trafficked to the membrane, and is functional, but not as much as a normal or wild type CFTR channel. A class 5 defect is a reduction in the amount of protein that's synthesized, even though that protein is fully functional. One mutation example here is the A455E mutation, where CFTR is synthesized in less quantity, but is still trafficked to the surface and is functional once there. A class 6 mutation is a reduction in stability, which results in an increase in channel turnover. In this case, the CFTR channel is synthesized, trafficked to the surface, and is functional, but is turned over more rapidly, which again results in a reduction in function. There are a few mutation examples of a class 6 mutation, but again, these are significantly less common than some of the others, like classes 2, 3, 4, and 5. In general, when you have 2 copies of a CFTR mutation, which results in either a decrease or a complete loss of function of the CFTR channel, it is possible to present with one or more symptoms of the pathophysiologic triad of cystic fibrosis. This triad is the possibility of affecting 3 primary organs due to the increased viscousness of the body fluids in those cases. The first pathophysiologic process is the accumulation of viscous mucus in the lungs. This accumulation of viscous mucus causes chronic infection, inflammation, and results in progressive airway obstruction like bronchiectasis and bronchiolectasis. The second component of the triad is excess salt in sweat, saliva, and tears. This can cause difficulty in regulating body temperature and a decrease in the functionality of sweat. Finally, the third component of the triad is pancreatic enzyme deficiency. Pancreatic enzyme deficiency is due to increased viscousness of secretions from the pancreas that result in these pancreatic enzymes not being appropriately delivered into the GI tract to aid in digestion and absorption. Pancreatic enzyme deficiency can cause poor digestion and malabsorption of fats primarily. This image illustrates the pathophysiologic process in the lungs more specifically. In a healthy airway, mucus in the airway lumen contains endogenous antimicrobials and is also fluid enough to carry away bacteria from inside the lungs, resulting in airway defense. However, in somebody with cystic fibrosis, the mucus has abnormal properties that make it extremely viscous. It's very difficult to undergo mucociliary transport and to release antimicrobial substances. Therefore, it is much more likely that bacteria will accumulate in the airways, cause chronic infection and inflammation, and lead to progressive airway obstruction. The clinical presentation of cystic fibrosis is highly variable because it depends on which mutation class is present in the patient. Some mutation classes, as I mentioned earlier, result in less severe clinical presentation than others. In general, the clinical presentation surrounds two primary organ systems, the pulmonary and then gastrointestinal system, with a couple of other possible effects being seen. In terms of pulmonary effects, you might see things like recurrent lung infections, such as bronchitis and pneumonia, an obstructive type lung disease, the presence of persistent cough, exercise intolerance, hemoptysis, tachypnea, barrel chest, and hypoxemia. On the gastrointestinal side, one of the most common signs of cystic fibrosis is meconium ileus being present at birth, which is a bowel obstruction that occurs when a child's first poop, called meconium, becomes even thicker and stickier than normal, creating a blockage in the small intestine. Other common signs related to gastrointestinal dysfunction include failure to thrive in infants and steatorrhea, which is excessively oily or fatty stool. Other signs that can occur are digital clubbing, which is a curvature or a rounding of the tips of the fingers, and infertility in males because of the increased viscousness of semen. In the diagnosis and assessment of cystic fibrosis, there are several assessment techniques that can be utilized. One is arterial blood gas measurement, which evaluates the amount of oxygen and carbon dioxide in the blood and is a measure of oxygen transfer as accomplished by the lungs. Another way to measure pulmonary function in cystic fibrosis is using spirometry, and that is probably the most common way of evaluating pulmonary function in patients with CF. One of the ways to evaluate the presence of cystic fibrosis and can be used in diagnosis is the sweat test, which is also known as the quantitative pilocarpine iontophoresis test, or QPIT. The sweat test essentially results in a forced sweating environment to allow the collection of sweat in a small area of the skin, and that sweat is then tested for chloride content. As demonstrated in the image here, an electrode drives the muscarinic agonist pilocarpine into the skin, which results in increased sweat gland activity, increased production of sweat, and allows sweat to be collected on a piece of filter paper or gauze that is placed against the skin. That sweat is then tested for chloride content. Normal sweat has a chloride content of less than 40 milliequivalents per liter, whereas sweat that has a chloride content above 60 milliequivalents per liter is considered diagnostic for cystic fibrosis. If the chloride content of sweat is between 40 and 60 milliequivalents per liter, follow-up testing is likely required to determine the presence of CF. Another diagnostic method that can be used in patient assessment is genotyping. The genotyping test only screens for about 100 to 150 of the most common mutations. But given that there are over 2,000 known mutations and new ones being discovered all the time, it is possible for a patient to have cystic fibrosis and still test negative on the genotyping test. One way to look at infection in the lungs is through a lung x-ray, or it could also be done through sputum culture to determine the presence of specific bacteria as well as to determine their antibiotic resistance profile. Definitive diagnosis for cystic fibrosis is based on either the presence of at least one of the listed clinical features, which includes meconium ileus, diarrhea or steatorrhea and failure to thrive, recurrent respiratory infections, nasal polyps, rectal prolapse, male infertility, and electrolyte depletion. Or the diagnosis could be made based on the presence of positive family history, so cystic fibrosis in a sibling, or a positive newborn screening test, plus lab evidence of an abnormality in CFTR function. There are two different ways to acquire lab evidence of CFTR dysfunction. One is a positive sweat test, and the other is the presence of a known disease-causing mutation on chromosome 7. As of 2010, all states require screening newborns for cystic fibrosis. And so the newborn screening test more and more has become the primary way in which individuals are diagnosed with cystic fibrosis, essentially at birth. The current median age of diagnosis is approximately 6 months of age. Given the significant consequences of lack of CFTR function on the activity of the lungs and the pancreas, there are several possible complications of cystic fibrosis, and they do depend a little bit on age. So in individuals under 18 years of age, in fact, the vast majority of them have no complications, around 25% of patients. In patients that do have complications, the most common are things like asthma and GERD, or gastroesophageal reflux disease. In patients over the age of 18, you're more likely to discover the presence of a complication. And those complications include cystic fibrosis-related diabetes, osteopenia, or loss of bone mass, asthma, GERD, and the presence of mental health disorders such as anxiety and depression. Some of the acute pulmonary complications can include pneumonia, atelectasis, which is the collapsing of a lung, pneumothorax that requires a chest tube, malnutrition in the case of pancreatic dysfunction, or pancreatitis. Some of the chronic complications that can occur over long-term living with cystic fibrosis include bronchiectasis, nasal polyps, liver cirrhosis, pulmonary heart disease, and diabetes. Although unfortunately there is no cure for cystic fibrosis and the disease does progress with time, there have been significant advances made in patient prognosis due to the presence of some additional therapeutics. As you can see in the graphic at the top, the annual mortality rate per 100 people with cystic fibrosis has continued to decline since 1988 and has gone from upwards of 2.5 people per 100 down to closer to 1 person per 100, which is significant progress. As I mentioned previously, the primary cause of death in individuals with cystic fibrosis is respiratory or cardiorespiratory failure, affecting 60% of those with cystic fibrosis. Also very important and not to be forgotten in patients with cystic fibrosis is counseling and other psychosocial interventions, given the propensity to develop mental health disorders and the possibility of suicide or drug overdose in this patient population. Fortunately, New strides are continuing to be made in the area of cystic fibrosis treatment, and new and better therapeutics continue to be marketed to patients, which will result in a longer lifespan among those with cystic fibrosis.